Hello everyone and welcome to Families First, Lessons Learned on Creating and Implementing an Integrated Service Delivery Model for Families Impacted by HIV, a session in our 25th Anniversary Lessons Learned series. My name is Pao Crego and I work at the National Abandoned Infants Assistance Resource Center located at the University of California at Berkeley. Our mission here at AIA is to enhance the quality of social and health services delivered to children and families affected by substance use and HIV by providing quality training, information, and resources to the professionals who work directly with these families. This session will be presented by Jennifer Lewis, who is currently a clinical assistant professor at the University of Southern California and a clinical supervisor at University of California, San Diego. A clinical social worker with over 17 years of experience in the field of HIV/AIDS, she is focused on direct practice, program development and administration, and research concerning behavioral prevention and intervention with adolescents and adults. Dr. Lewis has served in leadership roles in program administration at Integrated Medical and Social Services programs, where she authored and oversaw HRSA Ryan White grants and HHS Administration of Children and Family Services grants. Her research fosters multidisciplinary and cross-institution collaborations with the goal of implementing programming and developing novel behavioral strategies to lessen the impact of HIV on children, youth, and families. Before we begin, I want to remind you that you may ask questions via the chat feature in the lower left portion of your screen. We will answer questions at the end of the webinar, but please feel free to chat them in at any point. And now I'd like to turn it over to our presenter. Thank you for being here with us today, Dr. Lewis.
Thank you. It's absolutely my pleasure. All right. So my objectives for today are first going to be to describe the syndemic nature of HIV impacting families that can result in child abuse, neglect, and abandonment. Define characteristics of an integrated service delivery model for families impacted by HIV. Describe strategies to provide effective service provision to the entire family system. Identify strategies to establish trust and safety with HIV-affected families, and to identify challenges and solutions to engagement and retention and care for families affected by HIV. So the first really important point that I want to make is that HIV, for women especially, is now being thought of as a syndemic illness. That's a new term that's being used in the academic literature to really describe the multidimensional psychosocial stressors impacting women with HIV. Most of the women that we work with are women of color who have histories of substance use and active substance abuse, histories of complex trauma and violence stemming from early childhood sexual abuse or physical abuse and neglect themselves, and then domestic violence situations in their current lives. We notice that interpersonal violence with substance abuse is much higher in prevalence than the general population. So when we're working with individuals, women especially with HIV and trauma, we really have to pay attention to the co-occurring disorders, or what we're calling the triple diagnosis of HIV, psychiatric diagnoses, which may include PTSD, depression, anxiety, and also substance use disorders. And as we know, oftentimes substance abuse treatment and mental health treatment has been separated and siloed in terms of systems of care. And so when working with individuals with HIV, it really requires us to integrate our service provision in order to provide holistic services. So at University of California, San Diego, we have a program called the Mother, Child, Adolescent HIV Program, which was funded and developed back in the 80s really to provide family-centered HIV care to women, mothers specifically, and their babies with HIV. So we have an OB program. We help women reduce the chances of perinatal transmission. during their pregnancy. We have a pediatric program, so we provide HIV, comprehensive HIV, medical, mental health, and social services to HIV-positive children, adolescents, and the family system. So from the onset, the way it was developed was to provide medical care and nursing care, mental health care, psychiatry, substance abuse treatment, peer navigation, and case management, all in the same place. So the objectives of our Family First program are to seek and reduce child abandonment and neglect through early identification and implementation of a countywide integrated intervention designed to treat substance abuse and mental illness in HIV-positive parents, and to develop and support their role as active, engaged parents. Really, we were finding in our program that although we were providing many of the services that were needed for these families, that we were noticing high rates of child abuse and neglect. And we really felt like we had to add some additional services in order to address those. So our funding is a 4-year grant that is currently concluding through Administration of Children and Family and Youth Services, the Children's Bureau. And we also have funding from Ryan White Part D, which supports family systems of care. Our target population are HIV-positive women who are pregnant, parenting, or who may become parents who have histories of and or current substance abuse. And the goal is to prevent child abuse, neglect, and abandonment. So over the last 4 years, we have served 54 mamas and their children. We had the youngest child in the family we identified as the index child, the one who was most at risk of child abuse and neglect, and then their siblings. So you can see we had 28 children, young children, and 24 additional siblings. We had 2 fathers involved and 2 other caregivers. So you may be wondering why our number was relatively low for fathers, and the reason for that was because there was most often domestic violence in the family system, and we were not offering services to the family and the perpetrator of the abuse in conjunction with the family system. So just by looking at this chart, you can see generally the mean age was about 33, and the majority of our clients are Latina, 48%. And then equal amounts of pretty much African American, Black, or other. The risk factor was mainly heterosexual, with a 20% were also using intravenous drug use. 5% were perinatally infected with HIV through blood products. And they are now adults who are parenting, fortunately, many of whom had been in our program since birth. Let's see. So when we were developing the program, we thought, well, how could we really impact change? And of course wanted to utilize evidence-based practices so that we could feel confident in our approaches. So we combined all of the ones that had been proven effective and offered them as voluntary services. So first being medical care, we provide full-scope HIV primary care in our own clinic or in our adolescent or pediatric clinic. We provide psychiatry, so we have a psychiatric nurse practitioner who serves on our team and provides psychiatry. We also have a child and adolescent psychiatrist. We do substance abuse counseling. So we brought in, UCSD has a integrated substance abuse treatment program that the co-occurring disorders program. So we brought in one of their staff members to work with our clients specifically rather than referring them over to that program. And intervention-wise, they mostly use seeking safety and harm reduction approaches. So it's a non-abstinence-based program. We offer mental health counseling. The interventions, the evidence-based interventions that we chose were dialectical behavior therapy, seeking safety as well, and EMDR, in addition to supportive psychotherapy and psychoeducation. And then the component that was really new for us was parenting support. So we brought in a marriage and family child therapist to do PCIT and PIPE as interventions with parenting. And that was a really new opportunity for us to adapt some of those models to fit our clients' needs. And specifically with the adaptation, we were doing PCIT in the home. And so although it's an evidence-based intervention that's supposed to be used in a clinic setting, we were going and doing home visits because many of our clients had difficulty with ensuring child care and transportation. So I wanted to take a minute and sort of share some of the lessons learned as we wrap up our program, really from our process evaluation. We're in the process of doing our evaluation of our, we use the BASIS 24 to measure outcomes around behavioral health and mental health, and we use the API to evaluate attachment and things like beliefs and corporal punishment, and then we use the ASSIST to evaluate our drug use. And generally speaking, we're seeing reductions in all of those areas. We're seeing improvements in every single area that were significant. We noticed that we saw short-term change from baseline to 6 months, and then we didn't see much change from much additional change from 6 months to a year. And then we saw dramatic change again from a year to 2 years. So we have as we're just analyzing that data, we're noticing some trends in terms of mental health care utilization and expectations around change. But I wanted to sort of talk about the process evaluation a bit and some of the challenges that we had and opportunities that we learned from the systemic implementation of the program. The first challenge that I want to speak to is that, as I mentioned, we hired from different departments. So there was, of course, HR challenges in terms of borrowing staff and paying for their time. There were workload issues in ensuring that there was equity among staff, that no one provider was seeing more clients than others. So, for example, our family therapist people really appreciated that she could come into the house, and she had at times a very large workload, whereas sometimes the mental health clinicians doing work in the office had a smaller workload. We had challenges around who was going to, in that we worked as a team and our clients had contact with most providers, who was going to do the hard work to call CPS or child welfare. Oftentimes we'd try to call with the client in the room. I think that's best practice. But we recognize that there's a potential risk to the therapeutic relationship, and so there were challenges associated with that. Challenges with safety, certainly doing home visits. We were walking into homes where there was potential violence, domestic violence, and also violence in the family system, or risk of violence in the family system in terms of parenting. And many of our women are impoverished, and so some of the environments were less than safe. We were constantly on the lookout for bed bugs and rodents and all that fun stuff. And we also work as a small program in the context of a larger program that provides a lot of additional services not relevant to the family system. And so we wanted to be really thoughtful about while we wanted to build a team, we also didn't want to exclude ourselves or isolate ourselves from clinicians who were not members of our team. So some of the solutions that we developed with these challenges were, we really had a very clear vision of what we were trying to do as a group, despite other departments really what they needed or wanted. So, for example, other programs, because we are lucky enough to have grant funding and weren't as concerned about billing, we really tried to be compassionate towards other programs that were maybe jealous of us that we didn't have to bill for services, and they were having to do, so as a result we had lower volume. But we felt really strongly that we were doing very difficult work with high-risk families, and we needed to be very focused. We did have to bolster our clinicians' expertise and provide additional training so that they felt more secure. So we did training around reducing stress and compassion fatigue. We did safety training. We did additional clinical training around dialectical behavior therapy. And we needed to allow for some conflict to occur within our group. So, from the beginning, we were bringing people together that had never worked together before, and we needed to develop as a group. So some of the conflicts that emerged in the group were cultural differences around discipline for children. Specifically, we had an issue with a parent that was feeding their children primarily coffee and soda and junk food as their main source of nutrition. And there was discussion among some of our non-Latino staff, Latina staff, about maybe that was neglect. And some of our Latina staff said, well, that's how I was raised, so that's how I was fed. So we had some conflict in the group in terms of cultural competence. Addressing compassion fatigue, as I said, we all needed to. There was sort of a feeling that our clients weren't really progressing fast enough, especially in that 6 months to a year period, where we felt like, were we really making change and were we really making a difference? Were our clients really, motivated? And so we did some compassion fatigue training at that point. We had structured and unstructured supervision, so we met consistently once a week for clinical rounding supervision, and then we had a once-a-month mandatory administrative meeting that we met with. But we also had lots of unstructured huddles and meetings where we really needed to talk about the cases. We really felt like it was important to provide for clinician creativity and spontaneity and growth. Even though our evidence-based interventions were established, I tried to provide an environment where if they had a good idea, they could implement it, and we would, write that up in terms of changes we made. So one of the ideas was to do a seeking safety walking group. Many of our clients were struggling with health disparities related to obesity and diabetes, and trauma, and we felt like maybe it would be helpful, rather than doing a group in the office, if we actually went out into a park and did the seeking safety in a park. We also altered our systems in terms of doing a conjoint therapy. So we were finding that our psychiatry appointments were very well attended, but our substance abuse appointments were not. So we asked our substance abuse provider, actually they asked us, our substance abuse provider and our psychiatrist began working together in the same room at the same time with the client, and we found that magic happened. And then we really encouraged our staff to engage in academic papers and presentations. I think overall the course of the 4 years we did 4 or 5 around the country that really created a sense of excitement, and as we were analyzing our data and talking about our programs, it kept our staff very engaged. So some of the client-level difficulties we were having, family systems, clinical issues, it was obviously really challenging, I think, for all clinicians to work in a system where there's family violence and interpersonal violence, feeling like it's difficult to empower because our moms because of all the abuse that they've undergone. We also found that a lot of our clients have had trauma, and so they're really very skilled at working systems to their benefit and manipulation. And so we had to be really clear on what boundaries were so that we could provide a sense of safety for them. We found that a lot of clients were very fearful of relationships, of building new relationships, of being hurt. And as a result, the progress, the therapeutic rapport was slow to develop, and that oftentimes our clients really wanted to engage only when they were in crisis and not when they were doing well, which is, taxing on clinicians and also difficult for clients. So some of our solutions were, as I said, really having clear communication around expectations, including confidentiality, and that everybody on our team knows everything, and we share everything. There is no confidentiality among the team members. but that, of course, there would be confidentiality outside of the team. We established and prioritized safety. So we realized about halfway through that many of our clients really didn't feel safe in their environment, and that we really, before we focused on self-reflection or changing behavior, we really needed to focus on helping them to prioritize safety for themselves and their families. We really celebrated participation in the process rather than outcomes. So while progress in some cases was very slow, the interest of the client in wanting to change behavior, we really celebrated that and provided a lot of positive reinforcement around it. We also set it up so that it was voluntary participation. So all of our services were a la carte. You could participate in family therapy or parenting counseling, individual counseling, psychiatry. All of the services were presented, but none of them were mandatory. And we really tried to capitalize on the rapport with one clinician in order to increase the support network of the client. So, for example, if, as I said before, if our psychiatric nurse practitioner was able to establish rapport with our clients more easily, she would use her relationship with the substance abuse counselor to promote rapport with the clients. Transfer rapport, I should say. And that worked very successfully. So those were some of the challenges and solutions that we really developed and impacted our overall outcomes. For those of you who are working in HIV, you'll know that there's a very big push to support patient-centered medical homes, or these one-stop shops where we're providing all the different services in one place. Probably not a new concept for those of you who have been working in the field for a long time. It was, sort of the way that all services were provided, certainly in pediatrics and early HIV care. And I think there was a move towards individual services over time, and we're now looking at once again, providing these one-stop shop environments. And I can certainly attest to the impact of being able to provide all of the services in one place, and the dramatic outcomes that we see are reflective of that opportunity.
Great, thank you. Go ahead.
Yep, I was going to say that ends the presentation. I'm happy to answer any questions that people have.
Great. So one question is, so how have you and your program adapted due to the changing needs of families affected by HIV over the years?
That's a great question. So our program has changed in that our pediatric program is fortunately much smaller. So services for our babies that have HIV, we're doing such a great job with stopping perinatal transmission that we have very few kiddos that have HIV. For those of you who work in the field, you also know that funding to support the family system has been cut. So it used to be that Ryan White would fund the affected family members, and now they do not. I think as of about 4 years ago, they stopped providing funding for the family system. So it's been challenging because we believe that addressing the family system is critical, especially for women, in terms of managing some of the mental health and really creating an environment where people can stay engaged and retained in care. Which is the ultimate goal of, adherence and retention in care is the ultimate goal of the HIV strategy. So we've definitely shifted, but we've maintained our vision and our passion for addressing the family system. And we've had to seek alternative forms of funding in order to do it.
Great, thank you. And you mentioned earlier that magic happened when the psychiatrists and the substance use counselors work together in the same session with clients. Could you speak a little bit more to that, what that means specifically?
Yeah, I'd be happy to. at least in our experience, we had never provided those services in the same session before. So this was new to us, and staff came to me and said, hey, could we try this? And I thought, okay, I think. So we tried it, and we really did not set up systems initially to evaluate differences in outcomes for patients that participated in the conjoint treatment versus those who didn't. So I don't have, unfortunately, quantitative data. It just sort of took us by, it was sort of, we didn't have much forethought. But what I can share with you from a process perspective is that our clinicians had a much more powerful experience with one another in terms of teaching each other things that maybe they didn't know that weren't their expertise. So the substance abuse counselor was able to really teach the psychiatrist around harm reduction, and the psychiatrist was able to teach the substance abuse counselor about medication management. So they were, and the patient really wasn't having to reiterate their trauma over and over again. So the clinicians were having sort of this much more dynamic experience where they had more job satisfaction. They felt that they were making a greater impact. And we believe that the patients were having a more positive experience in that they weren't having to reiterate their stories over and over again. We found that sometimes clients tell us what they think that they're supposed to tell us. And not to say that they tell us what we want to hear, although they do that sometimes, but more so that they go to a psychiatrist and they think, oh, you just want to know about X, Y, and Z symptom. But they don't share that, they have, their family is being torn apart by, another family member or whatever the circumstances are, because they, in their head, they sort of compartmentalize us as providers unintentionally. And so it was really helpful for the providers to hear aspects that maybe wouldn't have otherwise been reported to them.
Wonderful. So we have a few more questions coming in. One of them is, was confidentiality an issue among the families?
Confidentiality between families really wasn't an issue. We found it a really grand challenge to actually get families and the clients to connect with one another. We had so many families that we were surprised by this, frankly, that haven't disclosed to anybody in their family system that they have HIV. So we had many women that are coming from, that live part-time in Tijuana and part-time in the U.S. and San Diego, and nobody in Tijuana knows their status. Many of their family members, or all of their families, don't know their status. And so it creates this dichotomous life. And so as a result, when people come to care in HIV care, they oftentimes don't want to meet other women that know their status. They are very isolated. So we found that it was a challenge to get them to come together, and really were only very successful as it related to our support group. That we were not really successful otherwise in terms of building a sense of community and reducing that isolation. But in terms of confidentiality between providers, we were very clear up front that everything that's shared gets communicated in the context of rounds or clinical case conferencing with one another, and so anything that's disclosed to one provider will be known to others. So I think the clear expectations were really helpful for clients.
Thank you. Another question is, what are some of the positive outcomes from your work?
So the outcomes specifically, as I mentioned, they're being analyzed right now. We evaluated the outcomes using the basis 24, AAPI, and the assist. So those were the quantitative measures that we used. If you're not familiar with basis 24, I can share with you that it looks at self-harming behavior, substance abuse, relationship discord, psychosis, depression, anxiety, and we saw reductions in all of those. The AAPI is a tool to measure attachment, beliefs in discipline and corporal punishment, really the connection between mom and child, and confidence in parenting. And so we preliminarily have seen improvements there as well. And then the assist is looking at drug substance use and in terms of quantity and type of substance, from a mild to moderate to severe in terms of usage. And so we have seen reductions in use both there, and it's also measured on our basis. So we have seen reductions in substance use. So everything seems to be pointing, at least preliminarily, in the right direction.
Thank you. So another question is, what alternative forms of funding have you been able to access to sustain this program?
Yeah, such a great question. So we were hoping, as many of the grantees on this call, that there would be additional opportunities through the Children's Bureau to pursue funding, and learned earlier this year that that was not the case, that funding had been eliminated from the federal budget. So we have written 2 proposals to SAMHSA that really support integrated care and trauma-focused care. So we have our fingers crossed that one of the 2 of those, or both of them, we would be fortunate to be selected. Certainly Ryan White funding is changing, and so that is also a risk factor. Ryan White has really encouraged its grantees to pursue reimbursement with the Medi-Cal expansion or Medicaid expansion to try to pursue reimbursement. So the challenges we have found with that are that not all services we provide are reimbursable. Things like we were offering transportation assistance and some child care, those ancillary services that are so critical. Additionally, case management is really difficult to get reimbursement for, at least in the way we do it in terms of intensive case management. So we have been looking for additional funding sources to support those programs, but certainly it's not been easy.
Thank you. We have another question about trauma-informed care, and are there ways that you have specifically integrated trauma-informed care to working with this population of families impacted by HIV?
Yeah, I think that's been a big change for us, and really where I feel like we did most of the work is around safety. I don't think a few of our staff, myself included, had an opportunity through the AIA to take a trauma-informed care certificate program. And so it really provided us an opportunity to look at our current practices, and we really noticed that safety wasn't something we were focused on because we sort of dismissed it, feeling like, well, our clients weren't safe, there's not much they can do about it, sort of feeling helpless to their safety challenges. And I think we moved past it in retrospect a little bit too quickly. And that may have been why we didn't see as much change as we could have. So we sort of shifted gears as we were getting our continuing education and really started to refocus on safety and frame for our clients about how to involve them in creating safe spaces for themselves. So I think it was really valuable, and I think that was the biggest lesson learned. We had been also doing some trauma-focused CBT, so we were using some of the interventions that are approved, as is Seeking Safety, I should say. So we were using trauma-focused interventions, but I think that we remembered or relearned the importance of safety.
Thank you so much. So the final question we have is, if someone wanted to create and implement a similar model, what are some first steps or kind of crucial aspects that you think they should include in their process in starting it?
You know, I think if I had it to do over again, there are many things I would do the same. The first being that I would identify the experts in the field in terms of individuals who have expertise, like substance abuse or psychiatry with people who have HIV, or mental health counseling with women who have trauma, and really hire those individuals to serve in those roles. So I really do think staffing matters. And then I think it's creating an environment, as I said earlier, where people feel like they're valued, that their expertise is valued, and they, are supported to try new things that maybe, because I think as professionals we need to grow as well. Otherwise, the slow growth with our clients can be really frustrating. So those would be some of the really, in retrospect, some of the things that I think were critical. I think if I had to do it over again, I would also focus on setting up systems around billing where not just only relying on the grant funding, but ensuring that we also had sources of other additional reimbursement so that, to really address the sustainability issues from day one.
Wonderful. Thank you so much, Dr. Lewis, for speaking with us today. I don't know if you have any last thoughts, or otherwise we can wrap it up.
Well, I would just say that, we're really grateful to the AIA for providing us this opportunity and even the opportunity to have lessons learned. Should anybody have further questions, they're thinking about starting this or they have had similar challenges, my contact information is there. Please feel free to use it. I will respond to you very quickly, and I'm happy to share more.
Great. Thank you so much. This was such a fantastic question. And I also would like to thank everyone who attended the session. You will find these slides attached to the follow-up email we will send out after this session, and you will also find in there the link to our survey evaluation. If you could take a few moments to complete that, we would greatly appreciate it. And finally, this is the last session of our 2-day series, Lessons Learned, that is open to the public. However, if you work for an AIA grantee organization, you still have a few minutes to register for the next session with Chapin Hall, focused on lessons learned from the cross-site evaluation. So thank you again, and have a wonderful day.